So let's start the discussion. So Yutaka, here in Europe, we put together non-granular LST with all the other flat lesion, like a 2 millimeter 2A adenoma. On the other hand, it seemed to me that your message is focused on non-granular LST. Can you explain to the Western community why non-granular LST must be a special focus?
Thank you very much. It's a really clinically important questions. So from our data, just recently published in GUT, the Japan polyp study data, the most of the missed region and advanced adenoma were LST non-granular type. And LST non-granular, the polyp shape is very characteristics and a little bit different from just small, just 2A or just small oneness. And those regions usually show the high grade dysplasia, even in a small tumor size. And it is also really challenging to detect, even by expert. And 0-2C region or LST non-granular usually mainly located in the right side column. So the recent cohort study, even doing the total colonoscopy, couldn't decrease the colorectal cancer deaths in the right side column. And some researchers think such kind of the right side column might derived from SSL, serrated pathway. But we don't think serrated pathway is a major cause of the missed lesion in the right side column, but LST non-granular type we may play an important role in the right side missed colorectal cancer.
Yeah, Pradeep, yeah, you come next, but I feel this point by Yutaka is very nice. We emphasize the serrated lesion, maybe because we are unable to detect the non-granular LST. Pradeep, give a comment from the European perspective.
I completely agree. I remember very well that back in 2005, when I came back from Japan and started talking to my colleagues in UK about non-granular LST, all my senior colleagues, I was a very young guy at that time, all my senior endoscopists said, oh, that doesn't exist in the West. That's a Eastern disease. It doesn't exist here. Then we started the bowel cancer screening program, and everybody started seeing, and things started changing. And now Yutaka is saying that even in Japan, endoscopists are missing non-granular LST.
Yes,
so
yes.
That makes me worry that how many non-granular LSTs we are missing in the West. So this is very scary. And to me, this is an ideal situation for AI. If AI can help us, then this is the area where we really need the help, not in finding these 2 millimeter and 3 millimeter and 1 millimeter polyp, which probably will never do any harm to any patient.
Yeah, absolutely. Yutaka, one of the expectation from European endoscopy, from artificial intelligence, may be somewhat to accelerate the procedure. So first, what is your withdrawal time when you do a screening colonoscopy? And are you expecting that Wise Vision will slow your withdrawal time because you have a friend on your side, you want to detect more non-granular LST, or will accelerate your withdrawal time? But first, what is the withdrawal time of Yutaka Saito when you do a screening colonoscopy?
Thank you very much. So now we are starting the prospective pilot trial using Wise Vision at our National Cancer Center. We are measuring our withdrawal time in the ascending colon, transverse colon, and sigmoid colon. As for me, my withdrawal time in the ascending colon, 1 minute. 1 minute.
So it's more about competence than withdrawal time.
And another important point, Professor Kudo always said, withdrawal time is no matter. So maybe we should train our eyes to detect flat region.
Yeah. Now, this is a good point, Pradeep, because if we don't have the competence to detect something, we can spend even 10 minutes. But if we cannot detect, we still miss. So probably competence is more important than withdrawal time. So probably wise vision can somewhat simplify this issue of the withdrawal time. Do you agree?
I completely agree. I think, Cesare, in endoscopy, in an effort to improve the quality of endoscopy, we've come up with some arbitrary parameters that we measure to see how we can measure the quality of endoscopy. These are not perfect measures, but we did not have any other way of improving the quality, so we created this withdrawal time. It does make sense to have the more time you spend, the more you should find. But as Yutaka highlighted very well, it's not related to time, it's related to the skill and expertise of the endoscopist. So as we go forward, I feel AI will completely change all these key quality parameters that we have defined. And we should come up with new parameters, new metrics, and not have a hang up about these old parameters that we defined before the AI era.
Yeah, good point. So let's move to IBD and then we come back to polyp for characterization. So, Yaru, one of the problems here in Europe is that we are not so good in using this activity index. It may be the Mayo, it may be the ulcerative colitis activity index we don't use, so we have poor inter-observer agreement. Is artificial intelligence the answer to this? And is it a bit a pity because we didn't become very competent in this? So what's your feeling? Will it replace human index?
Yeah, actually, I know that for the Mayo endoscopic score, there is no validation study, so the results. But most of all of the clinical trials use it for their Mayo score for their to evaluate in the clinical or endoscopic activity. But instead of that, for the recently UCEIS score is commonly used not only for the Western country, but also in Japan. So that would be already validated and they are easy to score there. So using that score rather than a Mayo endoscopic score, it will be more attractive to learn to the AI system, and then much more commonly used, I really hope so. So Mayo endoscope subscore is right now, it's a very, very easy, but it's very fuzzy. Actually, there is some score between Mayo 0 and 1, or Mayo 1 and 2. There's many, many kinds of situation we actually observed in the daily clinical practice. So maybe in the near future, as far as for the AI system, compared with the Mayo score or UCEIS will be much more commonly used. I really hope so.
Okay, Haru, every day in this period, for some reason, I'm doing at least one surveillance colonoscopy in ulcerative colitis every day. And so I need to use traditional chrome endoscopy, if not Pradeep get angry with me, okay? But when I use the traditional chrome endoscopy, and I'm not super expert, I spend at least 10 minutes in doing this procedure. So do you feel that with AI, we can detect flat lesion in ulcerative colitis without the need of traditional chrome endoscopy? Then I'm just curious about Yutaka and Pradeep if they have their own expectation on this?
Actually, yeah, thank you very much. Actually, basically, to make a diagnosis or localization as far as the basic standpoint is that for the clinical activity should be remission. So if there is some inflammatory mucosa, it is very, very hard to detect even in the specialist against the chronic dysplasia or cancer. So to do that, the medical treatment is very, very crucial to make an early diagnosis of colitis-associated dysplasia. And further, chromoendoscopy is very, very important and to detect the neoplastic region in the endoscopic remission stage. And the most important point is that for the redness is the currently most important findings to find the colitis-associated dysplastic region. We always check that kind of very, very small difference of mucosal redness. This is very important matter.
Any other comment?
For me, Cesare, I think putting indigo carmine in the colon doesn't take time. But in colitis, for me, what takes time is making sense of what I'm looking at. When I put dye in the colitic bowel, you see so many things. There's inflammation, regenerative patches, dysplasia, adenoma, and we get very confused. So making sense and making interpretation of those findings is what takes the most of the time. So if AI can take over that burden from me, it'd be fantastic. That will make my life so easy, improve patient outcome, and will make procedure very fast.
I think I totally agree with you. If the AI can learn using many samples, but unfortunately, you see associated dysplasia or cancer, the total number of that patient is extremely low compared with the sporadic current tumor. So at first, the deep learning step is the most crucial problems if we want to know that to find a modality using AI against colitis-associated dysplasia. That is the most biggest issue currently, I think.
Yeah, I also completely agree with your opinions. Even for us, the endoscopist, to detect the dysplasia, low-grade dysplasia or high-grade dysplasia in the UC is the most challenging. And the difficulty is maybe similar to the diagnosis of Barrett cancer. Because the lesion in inflammation is really challenging to diagnose. So AI will help such kind of difficult diagnosis in the near future.
Okay, let's move 1 second in characterization, then we move to Barrett. Yutaka, there is a challenge to import here in Europe the DLANET classification with an effort between our two societies. And when I did my exercise, I felt it was quite difficult to differentiate between DLANET 2A and 2B, and sometime between 2B and 3 when the area was really subtle. So do you feel that a wise vision can help in implementing DLANET classification in Western countries and somewhat close the gap between East and West in characterization?
Yes, absolutely. So the diagnosis, the differential diagnosis between JNET type 2A and 2B or 2B and type 3, sometimes also really difficult even for us, the expert, who developed the JNET classification, because the irregularity gradually change. And also the diagnostic criteria still a little bit different between institutions, even in Japanese expert centers. So for such kind of the genetic diagnosis, AI wise vision will really important role. I believe, strongly believe.
Yeah. Pradeep, can you comment on the competence of community endoscopy here in Europe in characterizing lesion? Because I feel most of us here don't characterize.
Well, the thing is, if you look at published literature, Cesare, you find that the literature suggests we are very good in optical diagnosis. But two comments about that. One is the literature is very biased. People only produce their best results. Second, majority of effort in the West about optical diagnosis is primarily focused on differentiating hyperplastic from adenoma. We don't have a lot of Western literature about adenoma versus SM1 versus more than SM1, which is what makes a big difference in the management of the lesions. So that literature doesn't exist. Those skills are very low. So there's a big investment that needs to go in there. And then also, if you look at the literature between hyperplastic and adenoma, which is what most of the Western endoscopists try to do, as soon as you move out from academic centers and passionate endoscopists to general endoscopists, you got so many studies, DISCARD2, the Dutch study, so many studies showing that the accuracy really drops down. So in true sense, although the literature, there are more than 100 papers showing how good we are, but it has not been implemented. We still don't practice it. So there's a big gap between what we show in the literature and what we practice.
So let's move to Barrett, and there is an inescapable question for you, Pradeep. So you spent your time in training all of us in using acetic acid. Will you train wise vision with acetic acid, or will AI kill acetic acid? So.
Well, I never see competition between two technologies. I think all the technologies we get are complementary to each other. I don't think there is any competition. The reason why we started using acetic acid was because it was impossible to find these flat lesions with white light. And in olden days, you know, NBI, FICE, iScan, they were also very dark. The resolution was poor. So it was impossible for these other technologies to help. So acetic acid was the best. And I still think acetic acid is very, very good. But now with these modern technologies and AI, I have a feel that acetic acid, the role of acetic acid might shrink down, but still will become relevant in those difficult cases. Like now, for example, when I'm doing optical diagnosis of polyps, majority of the time, I just use NBI or BLI. But when there's a difficult case and NBI, BLI doesn't help me, I go back to indigo carmine. And there it helps me. So I think you see the same situation which is likely to happen with AI, that if it is not conclusive, you use acetic acid, and maybe that will improve your confidence or your accuracy.
Okay, so I feel that it is time to close. So first, let me thank on behalf also of Yaro Ogata, our super speaker, Yutaka and Pradeep. I mean, amazing data. Let's thank again Hiro Inoue for having given us this space, and let's thank especially NEC. They revolutionized our life 10 years ago with face recognition. Now they are entering in the GI community, and I'm expecting the same spectacular result they had in any other field in the world. Pradeep, you want to close?
Very quick point. One thing we forgot to talk about was sizing. I think we can do all the characterization, but if we don't get the size of polyp correct, which we showed that the endoscopists are not very good, we will not be able to implement any of this information. So on that note, I would thank everybody.
Yeah, Pradeep, but Auro Inoue promised us that next year we will have a second special on NEC with the sizing. Thanks, guys. Bye-bye.
Yeah. Thank you, everyone. Bye.
Bye.